Hello everyone, this is Sasank Med. Today I'm going to be talking about acute decompensated heart failure management. This is bread and butter internal medicine. You'll have this a lot in internal medicine residency, and essentially the patient will come to the emergency department with new onset dyspnea, likely cardiogenic in etiology, and will have signs of volume overload such as pedal edema, crackles in the lungs, or elevated JVP. Can have clinical symptoms such as paroxysmal nocturnal dyspnea, waking up at night, difficulty breathing, or orthopnea, which is difficulty laying flat. But essentially, once you've determined that it's acute decompensated heart failure, first thing to do is assess the hemodynamic profile and triage accordingly. So if they're warm and dry, this is the best prognosis, can be managed outpatient. If they're cold and wet, they'll likely need ICU support. I'll explain what those terms mean in a minute, but basically warm versus cold, essentially you consider these things. Do they have altered mental status? What is their lactate? Whether they have cool extremities, narrow pulse pressure. Warm indicates normal perfusion in which the cardiac index is greater than 2.2. What is cardiac index? Cardiac index is essentially like the cardiac output divided by the total body surface area. Can also be calculated using pulmonary catheter that measures right arterial pressure. And then cold essentially indicates hyperperfusion in which the cardiac index is less than 2.2. Another sign of cold is narrow pulse pressure. Cool extremities also could be poor perfusion. And then the next classification is dry and wet. So basically, are they volume overloaded or not? So this is the presence or absence of congestion on exam, either in the lungs, JVP, or pedal edema. For JVP, make sure to use the ultrasound if possible. Look up how to do that. And then the majority of heart failure with reduced ejection fraction and heart failure with preserved ejection fraction patients will be warm and wet. If you're warm and wet, essentially you do a diuresis plus vasodilators, the exception being right heart failure. But another thing is if they're cold and dry, you want to give them inotropes and vasodilators because they're having poor perfusion. But let's talk about the history taking for heart failure. So for history taking, the acronym to remember is failure. So these are the decompensation triggers. So F, did they forget to take their medicine on time? A, arrhythmia. Do they have any past arrhythmias? Or are they currently in arrhythmia? Do they have any anemia or afterload problems? Afterload meaning hypertension or like valvular stenosis. I stands for infection or ischemia. So do they have any previous heart attacks or are they currently having a heart attack? Lifestyle, do they have a salty diet? Did they eat a very salty meal? U, upregulation of cardiac output. Are they pregnant? Do they have hyperthyroidism? R stands for renal failure, E stands for embolism, and then there's other triggers. So do they have a previously diagnosed cardiomyopathy that's getting worse? Do they have inadequate diuretic dose? Medicines such as NSAIDs, steroids, calcium channel blockers, anthracyclines, toxins such as ethanol, new worsened valve. Do they have a heart failure history? So any prior cardiomyopathy diagnosis? What is their dry weight? Their last pro-BNP? Their last TTE and ejection fraction? Their prior ischemic workup? Outpatient cardiology? Do they have an outpatient cardiologist? And do they have accurate palliative medical care? Social and family history, including substance use such as alcohol, tobacco, and any recreational drug use. Family history, including any history of heart conditions in their siblings or parents. Or admission considerations. So admission orders for acute decompensated heart failure are telemetry, monitoring, low sodium diet, daily standing weights, strict INOs, DVT prophylaxis, electrolyte replenishment scales. The magnesium, phosphate, and potassium are really good to monitor. So for cardiac ICU admission indications, make sure that this is essentially you send them to ICU if the ejection fraction is less than 25%, if their pro-BNP is greater than or equal to 2,500. If they have arrhythmia-induced heart failure, Black and Latino patients with heart failure are less be admitted to cardiology services. Yeah, this is interesting. There needs to be more investigation in that regard. But another thing is to avoid calcium channel blockers, NSAIDs, flecainide. Make sure you check The proBNP and the weight on admission, the acute decompensated heart failure is unlikely if the proBNP is less than 300, likely if it's greater than 450. It's difficult to interpret in chronic kidney disease and dialysis, maybe falsely low in obesity and heart failure with preserved ejection fraction. Next thing is screen and treat iron deficiency. You diagnose if the ferritin is less than 100 or ferritin is less than 300, and the transferrin saturation is less than 20%. The therapy is to replete with IV iron to decrease the symptoms, increase functional capacity, and possibly improve outcomes. So the early and acute management of acute decompensated heart failure is diuresis is the first step. The goal being is to decrease the central venous pressure and pulmonary capillary wedge pressure to optimize the Starling curve mechanics and relieve the symptoms. The initial therapy is IV loop diuretic. Start with 20 to 40 milligrams IV furosemide. If diuretic naive, otherwise start with 2 to 2.5 times the home dose, IV or PO. And for Bumex, it's important to remember that it's actually 1-to-1, so you don't need to do that calculation. And then there's no difference between continuous GTT versus bolus. And then for refractory diuresis, so basically this patient that doesn't get improved, so you can add metolazone 2.5 to 5 milligrams administered for 30 minutes before the loop diuretic. May need a right heart catheter to clarify the hemodynamics or inotropes to augment the diuresis. Acetazolamide 500 milligrams daily as well as dapagliflozin 10 milligrams daily may also augment successful decongestion. The step-up therapy is superior to the, what is RRT? Step-up therapy is superior to renal replacement therapy. Basically, that refers to hemodialysis or dialysis in the setting of cardiorenal syndrome. So worsening renal function, this is common occurrence and there will be mild creatinine bumps, but should not preclude the further diuresis. The endpoint is target resolution of signs and symptoms of congestion. Daily weights, hemoconcentration, lungs and JVP, and POCUS are useful adjuncts to ensure diuresis to euvolemia. B lines on lung ultrasound basically indicate or foreshadow increased risk of heart failure admissions and death. If there's acute pulmonary edema, non-invasive positive pressure ventilation may improve mortality and reduce the need for intubation. Vasodilators such as arterial and venous dilation can relieve symptoms by decreasing afterload, decreasing pulmonary capillary wedge pressure. Consider in severe hypertension acute mitral regurg or acute or aortic regurgitation. Essentially, this is saying that if you need to decrease the afterload or the pressure that the heart pumps against, then you can give these vasodilators. Examples of these are isosorbide dinitrate, hydralazine, nitropace, or captopril. If they're on the normal admission floor, then you can give nitro as needed or nitroprusside as needed. The home GDMT continuations, if their patient is not in shock or does not have new AKI, you can continue the GDMT during the acute decompensated heart failure. And then for GDMT, so this is if the patient has heart failure with mildly reduced ejection fraction plus or minus heart failure with improved ejection fraction. So you prioritize the initiation of low dose quadruple GDMT prior to discharge. So this is really important. So patient, when they're admitted and they're fluid dry, you're going to up-titrate their GDMT while they're admitted. It's very important to remember that GDMT cannot be done outpatient effectively. It can theoretically, but it's very important to see how the patient responds while they have inpatient admission. Make sure they're on the highest tolerated dose of their GDMT. Beta blockers that are initiated are carvedilol, metoprolol, succinate, prolol. This is indicated in the Copernicus and Merit heart failure trials. And make sure you use with caution if they have recent inotropes. So inotropes are medications that pump the heart harder. So then you have RAS inhibitors. So these are if the renal function is stable and they have no contraindications to ACE inhibitors or ARBs or ARNIs. You can initiate titrate ARNI, such as sacubitril, valsartan. This is proved in the Paradigm heart failure and Pioneer heart failure trials. Second line ACE inhibitors, ARBs. This is in the Consensus and Charm trials. And you can switch to ARNI from ACE inhibitors, ARBs, if no contraindications or cost concerns. There's a 36-hour washout period for ACE inhibitors prior to ARNI. And for MRA, this is the next medication, so you can initiate spironolactone or pleuronone if the creatinine clearance is greater than 30. This is indicated in the emphasis heart failure in Rails trials. Watch for rebound hyperkalemia after de-escalation of diuretics. And then you have the SGLT2 inhibitors. So these are dapagliflozin and pegfilgrastim, which reduce the mortality and heart failure admissions regardless of GDMT. This is GDMT dosing. You can pause the video here and take a look. But okay, let's talk about heart failure with preserved ejection fraction. The goal of this is to improve volume overload with diuretics and treat the comorbidities such as diabetes mellitus, hypertension, and atrial fibrillation, and make sure you add GDMT. So it's noted that SGLT2 inhibitors are found to decrease cardiovascular death and hospitalizations in patients with ejection fraction greater than 40%. Consider the spironolactone if there's normal renal function and potassium. And this decreases the cardiovascular death and admits in, I don't know what that means, but anyways, there's no proven benefit to beta blockers, ACE inhibitors, ARNIs, or ARBs. Finerenone and semaglutide are also indicated. So another thing to note is implantable cardioverter defibrillator is indicated if there's ischemic cardiomyopathy with ejection fraction less than or equal to 30% or less than or equal to 35%, with New York Heart Failure Association classifications of 2 to 3. It's basically like mild to moderate functional impairment of daily activities. Then CRT, what is... So CRT refers to cardiac resynchronization therapy, such as synchronized cardioversion or synchronized cardioversion. Yeah. So if ejection fraction is less than or equal to 35% and prolonged QRS plus or minus left bundle branch block with some with ejection fraction less than 50%. So this is basically saying that implantable cardioverter defibrillator is indicated if you have low ejection fraction, and cardiac resynchronization therapy can be used if less than or equal to 35% and prolonged QRS plus or minus left bundle branch block, and then also with ejection fraction less than 50%. All right, last thing, pre-discharge optimization. So it's important to document the discharge weight and their dry weight if possible, and their pro-BNP, and make sure they have appointment at the heart failure clinic, referral to cardiac rehab, and then optimize their GDMT as above. And for the diuretic plan, determine the maintenance of oral diuretic dose and provide specific instructions for taking additional rescue dose. Consider inpatient observation or maintenance dose, and decide if the patient needs potassium replacement. That is acute compensated heart failure.